So Anupama, hope everything is perfect, isn't it?
Yes, sir. Everything is perfect from our side. Good to go, sir. Yes.
Okay, shall we start? Sangeet sir, are you ready? What about our guest? Sangeet sir?
Yes, I request all the participants to mute.
Dr. Sanket, you can try sharing yours now. We are about to be.
Okay, that sounds good.
Yeah, so let me start. So good evening to all. So on behalf of IEEE Photonic Society, I welcome you all for this wonderful program. And I request Anupma, please welcome the gathering and introduce the chief guest of the day.
Yes, thank you so much, sir. So greetings to all participants. I welcome you to this session. And we are privileged enough to have with us a guest speaker, Professor Sanket Dhruva. He's a cardiologist and faculty member at University of California at San Francisco School of Medicine. He has conducted research around the safety and effectiveness of implantable cardiovascular diseases approved by US Food and Drug Administration for more than a decade and has been identified as an opportunity for various opportunities to strengthen the evidence base for such devices. He has also studied the use of digital health technologies in medicine, and his findings have been emphasized and the importance of preventive medicine to improve cardiovascular health. So with this brief introduction, I welcome you, sir, for your talk. Yes, sir, over to you.
Great. Thank you so much. Thank you for the invitation. Let me just share my screen here. One moment, please. Sorry, just 1 second here. Okay, are you all able to see that screen?
Yes, sir, we are able to see, sir.
Okay, great. Okay, well, let's go ahead and proceed. Well, I want to first thank Professor Subhash, Ms. Anupma Thakur, Dr. Naresh Chand. I appreciate the opportunity to be here and present to all of you, and thank you so much for your interest. So what we're going to discuss now are advances in prevention in cardiovascular disease. We're going to discuss novel therapies and treatments and technologies that have been developed in recent years, but most importantly, how to avoid needing them. I have no financial disclosures relevant to this presentation, no financial conflicts of interest. So here's an outline for today. We'll be discussing coronary artery disease, what it means in terms of to have a heart attack. We'll discuss treatments. We'll also discuss what atherosclerosis is, how it affects arteries throughout the body. We'll discuss heart failure and advanced therapies. We'll discuss cardiac arrhythmias and advanced therapies there. I'm just going to get my pointer, 1 second here. And then we'll spend a long portion of the presentation discussing risk factors for cardiovascular disease, including weight, body mass index, the importance of a heart-healthy diet, blood pressure control, cholesterol control, blood sugar control, the importance of physical activity and not being sedentary, and then as well, stress and anger, sleep, and avoidance of tobacco. We'll also then discuss new innovations around innovative digital health technologies such as blood pressure monitoring and activity monitoring. We'll discuss their promise, and we'll also discuss the evidence that surrounds them. Sorry, just get to the next screen here. So first, I want to provide a word about cardiovascular disease in India. 1/4 of all deaths in India are attributable to cardiovascular disease.
Hello,
Sanket, quite a few people are complaining that there is no audio. So on the chat box, quite a few people saying there is no audio.
Can you hear me now?
Yes, sir. Yes, sir. Perfect. Perfect. You continue, sir. Yeah, it's okay.
Okay.
Yeah, it's okay.
Okay, sounds good. So I wanted to emphasize that more than 62 million years of life are lost prematurely to cardiovascular disease in India each year. This is an estimate from 2016. More than 60 million years of life. So it's incredibly important for all people to understand, in particular in India, the impact of cardiovascular disease. In the Western population, I'm in the United States, in San Francisco. Approximately 23% of deaths from cardiovascular disease occur before the age of 70. So in the Western population, in the United States and Europe, it turns out the cardiovascular disease is generally a disease of older adults after the age of 70. But in India, 52% of deaths from cardiovascular disease occur before the age of 70. People in India tend to get cardiovascular disease, and they tend to get it at younger ages. And that's why it's incredibly important to know what it is and why it's important to treat cardiovascular disease. So let's first describe what a heart attack is as well as the treatment. So coronary artery disease is atherosclerosis of the coronary arteries, and I'll show some pictures in a moment. And these are the arteries that supply the heart muscle. These are actually the blood vessels that supply oxygen to the muscle of the heart. The heart is a muscle just like our legs and arms. But over time, cholesterol,
Sanket, people are putting comments that there is no audio.
Are you able to hear me?
There are quite a few people are writing there is no audio. Is something could be done differently?
No, sir, it's okay. Anupma, I think it's okay, isn't it?
Sir, I think some people have network issue, so they can rejoin, sir.
Yes, sir. Yeah, Naresh, sir, from our end, it's okay. From our end, no technical issue. Sangeet,
Okay,
sir,
I think people who do not have a voice, maybe they can log it again, you know. Okay.
Yes,
Sangeet,
sir.
sir. Sangeet, sir, yes, you continue.
Okay, that sounds good. Yeah, let me know if there's any problem. So over time, this cholesterol, fat, calcium, and inflammation are going to line the coronary arteries, and this causes a progressive blockage. And you may have friends and family members who've had symptoms of what we call angina or angina. And those are symptoms of chest pain or pressure, jaw pain, neck pain, pain radiating on the left arm, shortness of breath, fatigue with exertion or activity. Those are the symptoms of coronary artery disease. Now, what happens, this is what happens if the blockage occurs over time. But what can also happen, I'll show you some images, is there can be a sudden blockage. All of a sudden, a heart vessel is blocked because of all this cholesterol, this fat, this calcium, and this inflammation. And that means that the patient can have a heart attack, unfortunately, and this is called a myocardial infarction. Scientifically, myocardial infarction is the same as a heart attack, and this plaque of cholesterol, of fat, of calcium ruptures, and it leads to a platelet plug. So these are the coronary arteries that supply the heart. So this is the aorta here, and there's one vessel that goes to the right side of the heart. It's called the right coronary artery. Comes around to the right side of the heart and supplies, in general, the posterior portion of the heart, the bottom of the heart, called the posterior descending branch. So there's a right coronary artery, which is one, and there's a left coronary artery as well. This is called the left main, and it branches into two arteries. One is called the left anterior descending artery, which I'm showing here, which wraps around the front of the heart and supplies the anterior wall of the heart to squeeze. And then to supply the lateral wall of the heart is the left circumflex artery. So in total, three major arteries to the heart: the right coronary artery, the left anterior descending coronary artery, and the left circumflex artery. And what happens, as I said, this is what I hope all of your coronary arteries look like, that they're healthy, there's no blockages, it's just the blood that flows through normally. But over time, with the cholesterol, the fat, the calcium, the inflammation, there can be plaque buildup. And this is exactly the plaque buildup here, which will occur over time. So now let me show you a coronary angiogram of what normal coronary arteries look like. So what we do when patients are suspected of having coronary artery disease or a heart attack is we put in a catheter through either through the wrist or sometimes through the leg, through the femoral artery, and take some pictures under X-ray fluoroscopy of the coronary arteries. And this is what a normal right coronary artery, or RCA, looks like. This is what a normal left anterior descending coronary artery coming down the front of the heart. And this is what a normal left circumflex coronary artery looks like. Now, I'm going to show you what happens at the time of a heart attack. So this is an actual image of a patient who was having a heart attack. And this is a catheter that we're putting in. This is the patient's coronary arteries. This is the left circumflex artery that branches here into an obtuse marginal branch and an ongoing circumflex artery. And this is the left anterior descending. But what you see here, what you should see is a big artery that goes across the front of the heart, and there's nothing there. There's a little bit of dye that's stuck here that you might be able to see where I have my pointer, but there's no artery there. So essentially, unfortunately, there's no blood flow coming to the front of the heart. So this person is actively having a heart attack and not having any blood flow to the front of their heart. This is another view. We take views in multiple angles of the coronary arteries. Again, here you can see the circumflex artery, which is nice and open. And here you should be seeing a large artery coming down the front of the heart. So this person in the throes of a heart attack is getting no blood flow to the front of their heart, to the anterior wall of their heart. And I'm going to show you the consequences, unfortunately, of that, and hopefully the importance of also avoiding risk of cardiovascular disease. So now what we did in this case is we put a stent in, and now you can see this artery that you weren't seeing before in the front of the heart. Now you see all this blood flow is coming in, and this person is now getting blood flow to the heart, to the front of the heart. And you can also see when there's no dye engaged, you can see this little cage. It might be a little bit hard to see, but this open cage is a stent that's been put in to open up the heart. Here's another example, just a still frame of an acute blockage that's causing a heart attack. You can see in figure A. Again, this is a patient that had a stent. The stent got clogged off, and there's no blood flow at all. The patient has a heart attack. That part of the heart starts to die. And then in B, you can see after the blockage is opened up where the arrows are, now there's nice, strong blood flow going down the front of the heart. So I wanted to emphasize therapies that have developed over the past decades that have helped to reduce the risk of death from heart attack, and these include coronary stents, and this is what I was showing. This is a coronary stent, a little wire cage that can be placed into the heart, and there are different types. Initially, and still sometimes, they're bare metal, just metal that's put into the heart. There are also drug-eluting stents that actually elute chemotherapeutic medications. And there had recently even been the development of disappearing stents, which over time resorbed into the heart. I did want to say, all of you, and I'm sure some of you have had a role in the development of OCT, or optical coherence tomography, which has been an incredibly important imaging modality that allows for cardiologists to image the coronary plaque. In the United States, our regulatory body is the Food and Drug Administration, and first in 2010 approved optical coherence tomography, or OCT. Additionally, you can help to image coronary plaque to the micrometer range, including the composition. What I have here is an example of OCT, again, with great gratitude to those of you who are expert in photonics for these innovative developments. What you can see here is a coronary artery, and here you can see it. When I move my pointer, there's a blockage there. The arrow is pointing to this blockage. And the OCT images show a narrowing. All of this here, cholesterol, particularly fat, has led to a blockage. Now, the physicians, what they did was they put in a stent here, and now the blockage opens up. And you can see here, this where the arrows are pointing is this metal cage of this coronary stent. And then, but the stent is not actually well opposed to the wall of the artery, which is here. So the cardiologist, then they put in a balloon and they inflated it more. And you can see now the stent goes well against the wall of the coronary artery. So again, some truly innovative developments that have helped us to better understand the development in the imaging of coronary plaque, and obviously incredibly important developments. I also want to talk about, we talked about mechanical solutions like stents, but I also want to talk about chronic medications, which are incredibly important to treating coronary artery disease. All of these include aspirin, antiplatelet medications. Now, these medications have different names depending on the manufacturer, but I've listed the generic names here: clopidogrel, prasugrel, and ticagrelor. There are medications called beta blockers that reduce the demand on the heart. They make the heart squeeze less strong, as well as a little bit slower, which actually reduces demand and helps people to live longer, as well as statins that reduce cholesterol and reduce inflammation and have been shown to help people live longer as well. And I think there may be some messages in the chat. Are there any, if there are any specific questions, I'm happy to take those now, or we can continue. So I'm just looking here on the chat screen.
I think you can respond to the questions. Quite a few people have questions here. So you could go to the chat box and see what they have, so that, you know, those people.
Okay, that sounds good. I see a question around the sensitivity of coronary calcium scans. So coronary calcium scans are certainly helpful, and they do provide helpful information. But they only tell if there's calcium on the artery. Now, calcium is necessary for most people to develop coronary artery disease, but calcium, and so there will be a very small proportion, only a small proportion of people who don't have any calcium but still have heart disease. But calcium doesn't tell you the extent of the heart disease, and actually doesn't tell you how severe it is. And that's why those coronary angiograms, those pictures that I took, those pictures that I showed just a few minutes ago can help to provide more information about the blockages. I see another question about COVID-19 increasing the risk for heart disease. So that's a very interesting and important question. And actually it does, you know, obviously we only have several months of experience with COVID-19. We don't know what happens in the long term with COVID-19. We do know that inflammation in general, for example, the influenza virus or other viruses, are associated with a higher risk of heart attack. We can certainly expect the same goes for other coronaviruses. So we can expect the same for the SARS-CoV-2 virus. We can also certainly expect that people, when they are having a severe infection, when they're needing oxygen therapy, they're perhaps needing a ventilator, they're also having a higher rate of inflammation, which could increase the risk of heart attack. So certainly that could be a relevant feature as well. I see another question around diet control and food habits. So that's going to be a large chunk of our talk around preventative medicine. So we'll get there probably in about 15 to 20 minutes. So I'll hold off there. And I see another question about research on animal models, which are certainly important. I've chosen to focus on topics that are derived from animal models, but they're really focused in humans, so I can give you some tangible, actionable evidence that hopefully can inform healthier lifestyles for all of you. I see a question also around cardiac arrest. We're going to be talking about that and defibrillators in just a moment. and symptoms of heart failure. Again, we're going to be talking about that in just a moment. So I think at this point, perhaps I'll proceed, and then we can go forth and get additional questions in as well. And I see a question about statins, just as I'm changing. Yes, so statins are incredibly important for reducing cardiovascular risk. Again, we're going to be talking about that when we talk about blood cholesterol in a few minutes. So what I talked about first was coronary artery disease, which I said is the process of atherosclerosis affecting those arteries that supply blood to the heart. But what I want you all to know is that atherosclerosis, the same process, affects vessels throughout the body. So it can also affect the carotid arteries, which supply blood to the brain. The same process of plaque and inflammation and calcium. And what can happen is carotid stenosis can, again, develop in the arteries where the blood is flowing to the heart, and this can lead to a stroke. Similar to a heart attack, the pathophysiologic mechanisms of a heart attack are very similar indeed to those of a stroke. The therapies, similarly for people with carotid artery disease, include carotid endarterectomy, where vascular surgeons actually slice open the carotid artery and remove the plaque, or also carotid stenting. But again, we're going to talk about, excuse me, the importance of lifestyle therapies that can help to reduce the risk of carotid artery disease and reduce the risk of stroke. All of the preventative measures that I'll discuss will help to reduce the risk of heart attack and stroke, as well as peripheral arterial disease. Now, the process of atherosclerosis can also affect the vessels that go throughout the body. And so not only the neck, not only the heart, but also the legs can have the same effect, where blockages can occur in more than one vessel of the leg. The muscle can begin to die, and people feel symptoms of claudication, which means pain in the back of the leg, of the hamstrings, of the calves. Unfortunately, this can even sometimes lead to amputation because of the severity of the blockage. Again, the therapies are going to be the same, the preventative therapies that we'll spend the bulk of our time together discussing. These can include balloon angioplasty, stents, as well as vascular surgeries to bypass the levels of the blockages. But again, I want to emphasize, you don't want to get to the point where you have plaque reducing blood flow in the arteries to the legs. You don't want to get blockages in the legs, in the neck, in the carotid arteries, and you don't want to get at all either blockages in the leg arteries. I now want to discuss heart failure, which is a consequence of coronary artery disease. I want to discuss again the advanced therapies before spending the bulk of our time together on preventative therapies. So advanced therapies to treat the consequences of coronary artery disease. So now these blockages are one thing, but then a heart attack can really damage the heart's function. So normally the ventricles, and there are two ventricles in the heart. There's a right ventricle and a left ventricle. And normally these pump about 55 to 65% of the blood that comes in. So blood comes in from the right atrium to the right ventricle and then goes to the lungs, comes in to the left atrium and to the left ventricle. The left ventricle pumps this blood out to the rest of the heart, to your brain, to your kidneys, to your legs, to your liver, etc. And a normal, what we call ejection fraction, the proportion of blood that comes in to the left ventricle or the right ventricle and that's pumped out to the rest of the body, is about 55 to 65%. That's normal, and that's what I hope that all of you have. Now, what can happen with a heart attack is that there can be a reduced ejection fraction, which means generally less than 50%. And I'll show some images of this. Now, the symptoms of heart failure are shortness of breath with exertion. There can be shortness of breath when laying flat. People can also develop fatigue, swelling in the legs, as well as weight gain, which is water weight. Now, this is an echocardiogram. I'm going to play the images in a second. I just want to show you the four chambers of the heart. This is a left ventricle that pumps blood to the rest of the body, again, to your kidneys, your brain, your pancreas, your stomach, your legs. This is the right ventricle here that is a little bit small that pumps blood to the lungs. This is the right atrium. Blood from the rest of the body comes into the from the body. The deoxygenated blood comes in the right atrium, goes into the right ventricle where it gets pumped into the lungs. It gets oxygenated, comes back into the left atrium here, goes to the left ventricle, and the left ventricle is the most important portion of the heart because it pumps blood to the body. Now, this is an echocardiogram and ultrasound showing normal cardiac function. As you can see here, all of the walls of the left ventricle are working. This heart is pumping nicely. I would estimate probably about 60 to 65% of the blood that comes into this heart is being pumped to the rest of the body through the left ventricle. This is normal. Now, what can happen after a heart attack, by contrast, watch this video. So you can see now the left ventricle here is not pumping very well. You can see the walls of the heart are not squeezing very well. A little bit here in the anterolateral wall is squeezing, but all of the rest really not squeezing very well. And this is an example of a heart attack that led to what we call systolic dysfunction or cardiac dysfunction or left ventricular dysfunction, all synonyms pointing to the fact the heart is not squeezing well. And this is what you really want to avoid. Now, there are therapies for treating people with advanced heart failure where their heart is not squeezing very well. One of the options is heart transplant and get a new heart. But this is obviously not an optimal solution. There are many limitations to transplant. Transplant is a very high-risk surgery. There's a lifelong need for immunosuppressive medications. The immune system is suppressed, which means that people have a higher risk of heart attack, a higher risk of infections, because the immune system is not as robust, it's suppressed, so the heart is not rejected by the immune system. There's not a large supply of donor hearts. Everyone who might qualify for a transplant is not able to get one. And unfortunately, the process of heart failure often leads to damage in the lungs, in particular a process called pulmonary hypertension. So many people, they can't just get a heart transplant. You can't just get a heart transplant. It's not good enough because the lungs are damaged. So you need a heart and a lung transplant, which is obviously higher risk. The process of heart failure can also damage the kidneys. So people might need a kidney transplant along with the heart. You can imagine that's also a higher risk. And some people even need a heart transplant, a lung transplant, and a kidney transplant all at the same time. You can imagine the risk of such a procedure is going to be very high. I want to also discuss, as I said, the advances over the past several years. There have been the development of left ventricular assist devices, and I'll show you a picture in a moment, where blood flows passively into a pump and then it flows continuously to the rest of the body. And this is an example of a left ventricular assist device. Here you can see a suction pump sucks blood out of the left ventricle because the patient's left ventricle is not able to squeeze well, and brings it directly through a cannula right into the aorta so it can go to the rest of the body. Now, this individual with a left ventricular assist device is always connected to this device, always connected to this pump, always has to be connected to that. But again, a left ventricular assist device is not a perfect solution. There's still a very high risk of adverse clinical outcomes despite left ventricular assist devices. In 2 years, people who have a left ventricular assist device, 10% of these patients will have had a stroke, more than 40% will have had severe bleeding, nearly 1/4 will have had respiratory failure, almost 1/6 will have died. So we have solutions, we have therapies, but they're not a perfect solution, and I think that's why it's very important to employ and use preventative therapies, again, which we'll discuss in a few minutes, to reduce one's risk of cardiovascular disease, to reduce one's risk of heart failure, to reduce one's risk of needing these therapies. So let's shift now and discuss cardiac arrhythmias and advanced therapies. So the heart contracts based on the transmission of electrical impulses. So the heart, at its heart, truly is based on electricity. there's a conduction system. Now, what I have here is a picture of an EKG that shows the electrical signals that go through the heart and innervate it, allowing the heart to pump. Now, what happens with a heart attack, as I showed you on those coronary angiograms, is that can lead to a process called sudden cardiac death. So a heart attack means that the cardiac muscle, a small or a large portion, has died, and that leads to electrical instability, and that leads to the formation of because of the formation of a scar. So the death of the cardiac muscle can lead to cardiac arrhythmias, which is electrical instability, and that can lead to what we call sudden cardiac death. When you hear of someone who may have died of a heart attack in their sleep, this is sudden cardiac death. When you hear of someone who was reading a book, was going for a walk, suddenly clutched his or her chest and died, this is sudden cardiac death. And this is due to the electrical instability that leads to what we call ventricular tachyarrhythmias. You may have heard of arrhythmias like ventricular tachycardia or ventricular fibrillation, VFib or VF. Can also lead to high-grade atrioventricular block. The heart is basically not able to pump. And as soon as the heart is not able to pump blood to the rest of the body because of this electrical instability from a heart attack, unfortunately, the individual dies. So fortunately, therapies have been developed that can reset the heart rhythm and possibly save a patient's life, including an AED or automated external defibrillator. You may have seen on TV when somebody has this hooked up, shocked back to life. And even in the past 2 decades, devices that can actually allow patients to live with this implanted in their heart, an implantable cardioverter defibrillator. These are external. An implantable cardioverter defibrillator can be used to treat sudden cardiac death because arrhythmias can happen anytime. So this is an implantable cardioverter defibrillator, and generally there's at least one wire that goes to the right ventricle, what we call a lead, an electric lead. Generally one to the right atrium, sometimes in some patients with heart failure also to the coronary veins on the left side of the heart. And essentially what these devices do is that they monitor every single heartbeat, and they can provide an internal shock when that might be needed to help to reset the patient's cardiac arrhythmia, to reset the cardiac rhythm. So again, very impressive therapies that have been developed, but these are not a perfect solution. These are not a panacea. This is why people need to reduce their risk of cardiac disease, because even after having an ICD placed, there are high rate of adverse outcomes. After an ICD placed, still approximately 15% of people will die within 2 years. There's still a complication risk. Remember, these are mechanical structures, foreign bodies that are put into the heart. They can have complications. They might not work as intended. They might be a nidus for infection. So there's a complication risk of 6% every year. And unfortunately, still about 1/3 of the shocks are what we call inappropriate. So this means that a patient might have a different cardiac rhythm, like atrial fibrillation, and might get a shock internal to the chest. Now, I've talked with patients, and there's a lot of published literature about this. Some patients report that it feels like being hit by a truck. Some people even get post-traumatic stress disorder. They compare it as similar to getting shot. People who've been shot with a gun, this is what they compare it to because the pain is so severe from this inappropriate shock. So what I'm trying to emphasize is you really want to be in a place where you don't need these therapies. You don't need to get there where you need a defibrillator because of heart failure. And I also just want to mention, I have, throughout the talk, I have placed citations with at least the first 3 authors of original research articles that have been published in peer-reviewed medical journals from which I'm presenting this information. If that's of interest, obviously, I'm happy to answer questions. So that was the section on the advanced therapies. I'll take a moment and just look at some of the questions, and then what I want to do is now really then focus on preventative medicines. And reducing cardiovascular risk. So let me just see here. I have a question about the symptoms of heart failure, which I think we've described, and COVID-19 increasing the risk of heart disease. Absolutely. Again, we're learning more and more about COVID-19 every day. We've only, unfortunately, learned about this disease for the past 8 months, and the research is developing more, but there is an increased risk of clots, and there are some suggestions that anticoagulation, that is the use of blood thinners, can help to reduce the risk of adverse events, but there's still need for additional testing. Someone asked about statins. Again, we're going to discuss that. Doing cataract surgery with LVH. I don't want to give any individual medical advice, but left ventricular hypertrophy is the thickening of the heart as a result of many things such as hypertension and valve disease like aortic stenosis. Experimental methods, a question about that, and a question, which indeed there are a lot, question about lifestyle changes, which we're going to discuss, and also the difference between cardiac arrest, heart failure, and cardiac arrest, heart attack, and heart failure. So that's what I've described. So cardiac arrest is that process of sudden cardiac death. That's a synonym for cardiac arrest, which is a consequence of a heart attack. We discussed heart failure as well. So just to sort of step back, excuse me, patient can develop a heart attack, which can then lead to the electrical instability which leads to sudden cardiac death or cardiac arrest, and can also, which is a sudden thing that can happen any time, can also lead, unfortunately, to a heart failure. Again, the images, the echocardiogram I showed you where the heart was just not squeezing very well, can lead to those symptoms. Again, question about statins, which we'll discuss. Techniques for maintaining a beat of a heart for a person with a high heart rate beating. Again, I don't want to give specific advice, but the key is to understand why is the heart beating faster, and there can be a lot of reasons for that, which again I'm happy to discuss. There's a patient who's undergone a quadruple bypass surgery with a high HDL that's now gone down. We're going to talk about lipids. We're going to talk about cholesterol soon. There's a question about atrial fibrillation and ventricular fibrillation, which is more common after a heart attack. So actually, ventricular fibrillation, again, defib is the sudden cardiac death or the sudden cardiac arrest that we talked about. Atrial fibrillation is an arrhythmia of the top portion of the heart. We're not going to discuss, it's not necessarily related exactly to coronary artery disease. The risk factors are the same, but it is a little bit of a different process, and I'm happy to talk about that a little bit separately. But a lot of these preventative therapies will also reduce the risk of atrial fibrillation. A question about improving HDL cholesterol. Again, we'll discuss that in a moment. And then what are techniques that can be utilized in an emergency setting in order to help a patient? So again, there are a lot of therapies that can be used in an emergency setting. We've discussed some of those, which includes things like the coronary stent procedure. We've also discussed the defibrillator, which can help to reduce the risk of heart attack. The risk of sudden cardiac death, ventricular fibrillation, cardiac arrest. So now we've spent some time together. So now let's go and talk about preventative medicine. And what I'm going to do is I'm going to walk through and I'm going to have data and information that are very specific to South Asians, very specific to India and to Indians around weight and body mass index. We're going to talk about diet, blood pressure, cholesterol, blood sugar, and diabetes. We're going to talk about novel things around physical activity, but also issues that a lot of you may not know: sedentary time, stress and anger, the importance of sleep and regular sleep, and avoidance of tobacco. So we're going to dive into all of these now sequentially. So I can't emphasize this enough. I hope that this talk will be important. I want you to all prevent yourself from getting there. Prevention is the key to reducing the risk of coronary artery disease and its cardiovascular manifestations. Prevention is incredibly important. Here's what we're going to walk through: the importance of controlling one's weight and body mass index. Again, we'll talk about this. The goal is felt to be at least less than 25, but even in South Asians, unbelievably, the recommendation is even less than 20, which I'll discuss. Really, the importance of weight control is incredibly important. Ideally, one's weight would be checked at least on a monthly basis. The importance of blood pressure control. Ideally, a blood pressure of less than 130/80. Check that minimum every 2 years. Blood lipids and cholesterol. And again, we're going to be talking about all of these sequentially in order. A low density lipoprotein or LDL cholesterol of less than 100 or even less than 70. An HDL of at least 40, ideally greater than 50. Triglycerides, ideally less than 150. We'll be discussing blood sugar and blood sugar control. A hemoglobin A1C of less than 6.5% or a fasting blood glucose of less than 100. We'll be discussing the importance of physical activity, at least 150 to 300 minutes of moderate activity weekly. It can be less if it's more strenuous activity, as well as the importance of strength training. We'll be discussing minimizing sitting time. I know many of you may be sitting as you listen to this presentation, but hopefully minimizing that over time. Minimizing stress and anxiety, and the importance of ideally a regular 7 to 8 hours of sleep. Let's now discuss, many of you may know that Indians tend to have a higher cardiovascular risk than those around the world. Why is this? If you look across the world at Europe, Asia, Latin America, North America, Australasia, the highest cardiovascular risk is in India. This is incredibly important, and there are many hypotheses as to why this might be. One of the reasons is because Indians tend to have greater, what we call visceral abdominal fat, and greater insulin resistance and similar body mass index to European population. So let's look at that. So this is a picture of the abdomen. These are the abdominal muscles. Everyone also has subcutaneous fat, which is fat that is closer to the skin and is around the abdomen, but also around the arms, around the legs. But unfortunately, what happens is that South Asians, Indians tend to develop what we call visceral fat. And this is fat that goes around the liver, around the pancreas. It can also go around the heart. There are genetic risks, unfortunately, that lead to the development of this visceral fat. And this visceral fat is actually metabolically abnormal. It leads to abnormalities that cause things like diabetes and abnormalities of cholesterol. And for some genetic reasons, Indians tend to develop a lot more of this visceral fat than the subcutaneous fat, which is more metabolically benign. So even just gaining weight in an Indian individual can leads to this visceral fat deposition. There are also many genetic risks, such as around different cholesterol markers and higher rates of inflammation. But also what I'll describe and what is in all of our control is lifestyle as well as behavioral changes, which can help to reduce cardiovascular risk. So in the United States, where I live and practice, here are the cutoffs for body mass index, for a regular body mass index. People are considered to be normal if their body mass index, which is the weight in kilograms divided by the height in meters squared, is between 18.5 and 25. That's considered normal in the United States and Europe. If you get above 25, it's considered overweight, and above 30 is considered obese. But this is in the US and Europe. Actually, the ideal body mass index differs by race. This is an incredibly important peer-reviewed publication that was published a few years ago looking on the y-axis at metabolic abnormality and on the x-axis at the body mass index. Now, whites or Caucasians are here in this dashed line that I'm tracing, and approximately 30% will have metabolic abnormalities at that rate of 25, and that's why the cutoff is 25 for an abnormal body mass index. Now, this line here is of South Asians. 30% of South Asians will have metabolic abnormalities that lead to diabetes, cholesterol abnormalities, as well as the risk of coronary artery disease, carotid disease, peripheral arterial disease that I described at a BMI of 19.6. So at a significantly lower weight, South Asians will be developing all of these metabolic abnormalities. It's incredibly important to control one's weight. And let me describe a little bit more about the South Asian diet. Unfortunately, many peer-reviewed studies have shown that the South Asian diet tends to be relatively high fat, despite often being vegetarian. I'm sure many of you on this call are probably vegetarian. One would assume that that actually leads to a healthier diet, but it turns out that unfortunately Indians actually have a high rate of saturated fat intake. They also have a relatively high rate of omega-6 polyunsaturated fatty acids. We tend to use a lot of vegetable oil in our cooking. Unfortunately, these are linked to fasting levels of high insulin, again, which causes metabolic abnormalities that lead to the development of coronary artery disease and cardiovascular disease. We tend to have a lower risk of omega-3 polyunsaturated fatty acids, which come through, for example, fish or fish oils. Our diet also tends to consist of a relatively high content of carbohydrates, which also leads to a lot of these metabolic abnormalities. There's an average of nearly 50% of the total calories that are consumed by Indians are from carbohydrates, compared to an average European meal where it's about half that, about 25%. Now, I want to present, it's very hard to study diet and its relationship to cardiovascular disease, but there has been one rigorous randomized clinical trial that was conducted in Spain, and I think we have a lot of humility about how it can apply to the diet of Indians, but I think it's still important to talk about because this is the largest randomized controlled trial that really shows the effect of diet, and this showed the benefit of a Mediterranean diet. So this is a multi-center clinical trial that was conducted in Spain of nearly 7,500 people. There were 3 different arms, and I'll show you the results in a moment. One arm was a Mediterranean diet where people were incentivized to use extra virgin olive oil in their diet. The other arm was where patients were advised to consume high rates of mixed nuts for their calories. And then the third arm was a control arm where people consumed a regular diet and had some advice about low fat. Education was provided on a quarterly basis, including for the people who were randomized to receive extra virgin olive oil, they received free extra virgin olive oil. Those randomized to receive mixed nuts received those for free, and then there were some non-food gifts for the control arm. Now, what's amazing about this diet study, which was published in the New England Journal, that after about 5 years, both the olive oil and the nut-based diet had a lower rate of heart attacks, stroke, or death from cardiovascular causes. The relative risk of death, the hazard, was about 0.7 for both extra virgin olive oil group as well as the nut-based group, about a 30% relative reduction. Here are the survival analyses. Now, these show on the y-axis the rate of the primary endpoint in this randomized clinical trial of what we call acute myocardial infarction or heart attack, stroke, or cardiovascular death. Now, in the gray is the control diet, and in the orange and the green are the Mediterranean diets focused on nuts and extra virgin olive oil. You can see these risks are lower for the people who receive these these diets. Now, Certainly, this is a trial that's conducted in Spain. We have to ask about the applicability of the diet to South Asians, to Indians like us. But I think that there are still some lessons that can be learned. In the Mediterranean diet, what was recommended is olive oil, tree nuts and peanuts, fresh fruits and vegetables. Now, these are all items that all of us can consume, that we can purchase, that we should be focusing on. Fresh fruits, 3 servings or more a day. Vegetables, at least 2 servings a day. Nuts, at least 3 servings a week. Also, high in fish, this may not be possible for some of us who are vegetarian. Consuming legumes, 3 servings per week. And then items that are also dispersed. These are universal. Avoiding soda drinks, avoiding commercial bakery goods like sweets and pastries, avoiding spread fat, avoiding red and processed meat. So this randomized clinical trial has shown has lessons for all of us. There are things that we can all certainly focus our diets on and consume, and there are also things that we can avoid. And also one thing that's common in the Indian diet is palm oil, again, trying to avoid palm oil and a lot of these things like soda drinks. So I think that there are a lot of lessons which we are able to learn from this randomized clinical trial, how we might be able to change our diet to focus and derive some of those benefits, to have a lower risk of heart attack, to have a lower risk of stroke, to have a lower risk of dying from cardiovascular disease. I also want to discuss the importance of blood pressure control. Now, this is incredibly important. Obviously, it's intuitive, but it's important because high blood pressure exposes all of the arteries around the body to high pressures, and that can damage the arteries. That can damage the arteries supplying the heart. That can damage the arteries supplying the brain. A normal blood pressure is less than 120/80. An elevated blood pressure is anything above 120. If you're between 120 and 129, this is a systolic blood pressure. Ideally implementing lifestyle change, which I'll show in a moment. And then hypertension is defined as a blood pressure, a systolic blood pressure of greater than 130, or a diastolic blood pressure of greater than 80. Again, lifestyle changes are always important. And it's also important that people who with higher cardiovascular risk have a higher blood pressure lowering attempt. Here are some of the lifestyle changes. Again, I'm really trying to emphasize the lifestyle changes that all of us can make to reduce our risk of heart attack, stroke, heart failure, and death. Controlling blood pressure is incredibly important. So weight loss is very important. On average, dropping 1 kilogram of weight can lead to about 1 millimeter of mercury drop in the blood pressure. People who lose weight can get a benefit of about 5 millimeters of mercury in lowering their blood pressure. And this is for people with elevated blood pressure, even people with a normal blood pressure to lower their blood pressure through weight loss. The diet is so important to focus on fruits and vegetables, whole grains. Again, can lose. Even people with a normal blood pressure can drop their blood pressure by about 3 millimeters of mercury. Those with elevated blood pressure even more. Reducing salt intake. Physical activity, we'll spend some time talking about this. Again, helps to lower the blood pressure. Physical activity resistance can also be important and can help to lead to, this is resistance training, which can help to lead to lower weight. Alcohol consumption, obviously, it's a risk. It's certainly not advised for people who don't start drinking, but avoiding drinking too much. Less than 2 drinks per day in men and less than 1 drink per day in women. Again, reducing the risk of alcohol can help. Just 1 minute, let me just get the light, just 1 moment, please. Additionally, it's important to now talk about cholesterol. We spent a significant amount of time talking about cholesterol. So there can also be, what I want to emphasize for all of you is that total cholesterol, a lot of people talk about a total cholesterol. honestly, that's really a meaningless number. So the goal is to optimize one's cholesterol level by lowering the LDL cholesterol and increasing the HDL cholesterol to the extent that's possible. And we're going to talk about both of these in the next few minutes. The cholesterol, the total number doesn't really matter. You want this LDL cholesterol to be as low as possible, this HDL cholesterol to be as high as possible. A patient's cholesterol goals are related to their risk of developing cardiovascular disease. Higher risk patients should have more aggressive cholesterol management. And there are various risk calculators. What's most commonly used and publicly available, easily available, is what's called the ASCVD, or the Atherosclerotic Cardiovascular Disease Risk Estimator. It's used in the United States and easily available through a quick online search that can help to provide one's estimate of cardiac risk. So now let's talk about increasing the LDL cholesterol, I'm sorry, this is backwards. Decreasing the LDL cholesterol and increasing the HDL. I apologize for the title here. The LDL cholesterol, you want to minimize this. This is the bad stuff. This leads to plaque buildup in the arteries and to the consequences like heart attack, stroke, and other adverse things that we don't want. The goal is to reduce the LDL cholesterol, and you can reduce this through reducing the intake of saturated and trans fat and increasing physical activity. These are guaranteed to help improve the LDL cholesterol, and that means reducing the levels of this bad cholesterol. For many people, unfortunately, reducing the saturated and trans fat intake, increasing activity, isn't good enough. It doesn't reduce the LDL cholesterol enough, leads to insufficient results, and therefore people might take a statin medication. And I've listed the generic names. These have different brand names in India, but like the atorvastatin, simvastatin, lovastatin, rosuvastatin, pravastatin, and pitavastatin. So these medications can also help to reduce the risk, reduce the LDL, reduce the bad cholesterol, and help to improve cardiovascular risk. And then HDL cholesterol, now this is the good cholesterol. That's why I have it in green here. It actually removes cholesterol from the arteries. It takes it to the liver where it can then be excreted, removed from the body. Unfortunately, increasing HDL cholesterol is challenging. Strategies like weight loss, increasing physical activity, more higher consumption of olive oil, a higher consumption of nuts can help with the HDL cholesterol. It's also very important to, and I might actually take some questions now about cholesterol, because I know that this is a topic that's on a lot of people's minds, and understandably so. So I see a question about extra virgin olive oil. Is it good for the heart or for blood pressure patients? Absolutely. Extra virgin olive oil, as I showed, diet consisting of extra virgin olive oil has been shown to even help people live longer. It's incredibly important to consume olive oil to the extent possible, and even reduce the use of other oils like vegetable oils and palm oils to the extent that might be possible. I see a question about advisable to take peanuts and cashews along with almonds and walnuts. Absolutely, 100%. A diet with a variety of nuts is very good. Again, it's been shown to reduce the risk of heart attack, reduce the risk of stroke, reduce the risk of death. A variety of nuts is incredibly important. I see a question about does red wine help in boosting up HDL? If so, how many milliliters per day is a safe bet to drink? Now, this is a good question, and it's tricky. So red wine does boost the levels of HDL cholesterol, and it can have a small to moderate impact. It's not going to bring a level from 30 to 55, but it can help. Now, the tricky thing is that alcohol also can have other adverse effects. It can also slightly increase the blood pressure, and most problematically is when it's used beyond the use. What's recommended is less than or equal to 2 drinks per day in men, and less than or equal to 1 drink a day in women. Now, when the red wine is consumed in excess of that, there's obviously certainly many risks, and even unfortunately for some people, consumption of too much alcohol addiction, or abuse. So what's generally recommended is for people who consume alcohol to focus on red wine, again, less than 2 minutes a day, less than 2 drinks a day, and less than 1 drink per day, less than 2 drinks per day in men, less than or equal to 1 drink per day in women. But it's not recommended that people who don't drink start just for the HDL cholesterol lowering, because there can be these other risks, such as, again, alcohol addiction and abuse, and some of these, unfortunately, adverse consequences from that. Let's see, a question about statins that may cause myositis and they can lead to cramps. Yeah, that's a good question, for sure. Unfortunately, the statins, they can, in small numbers of people, lead to cramps. What's generally happened is these risks are generally low. It's not very high to have the cramps, and what oftentimes happens is changing from one statin to another can actually help to reduce those risks of cramps. There's a question about myositis, which is inflammation of the muscles. Again, that can occur, but I think that it's not a common occurrence. It's incredibly rare. There are hundreds of millions of people in the world who are on statins, and the proportion of people who have actual myositis, muscle inflammation, is very rare. It does happen, but it's very, very rare. And people do sometimes have these. Again, we're talking on the order of a few percent, can benefit oftentimes from changing to a different statin. I want to also talk about the importance of blood sugar control and diabetes. So diabetes is defined as a fasting glucose of greater than 126 milligrams per deciliter, or hemoglobin A1C, which measures the blood sugar control over the past 3 months of 6.5%. Ideally, fasting glucose would be less than 100, even between 100 and 125, or a hemoglobin A1C between 5.7 and 6.4% is called prediabetes. You can see I have some pictures of the sweets that many of us Indians like to consume, and which can increase the risk of diabetes. For both conditions, for diabetes and for prediabetes, there's a need for major lifestyle changes, avoiding sugar, losing weight, and increasing physical activity. I want to talk about diabetes specifically in India because there are some very concerning facts. The diabetes prevalence, unfortunately, has changed in the past 2 decades. In urban areas, it's nearly doubled from 9% to 17%. 17% of all Indians living in urban areas have diabetes. In rural areas, it's quadrupled in 20 years from 2 to 9%. An estimated 101 million people in India will have diabetes in 10 years. And which is actually different from other countries. There's a higher burden of diabetes in wealthier and more well-educated individuals in India. Diabetes is getting out of control, and it's incredibly important to implement the lifestyle changes of losing weight and exercising and controlling the content of one's diet in order to reduce the risk of diabetes and its adverse cardiovascular consequences. I want to provide some recommendations about physical activity. Physical activity is incredibly important. I know it's harder with COVID-19, and we'll be discussing that in a moment as well. The recommendation, and I know this might seem high, is 150 to 300 minutes of moderate intensity aerobic physical activity a week. This means brisk walking. Some of you may swim at the gym, recreational swimming. excuse me, biking 5 to 9 miles per hour. Or you can cut that time in half. If it's vigorous intensity aerobic physical activity, that means jogging or running, actively swimming laps, or biking at a faster speed. And it's also important to perform muscle strengthening or resistance training activities of moderate or greater intensity that involve ideally all the major muscles at least twice a week. So aerobic physical activity, the times here, I know it might seem like a lot, but it's important. It's necessary to reduce one's risk, as well as what sometimes people don't realize, the importance of muscle strengthening activities, which I've listed here. Now, what about physical activity in India? What is physical activity in India? What is it like? There was a nice study which was conducted in 4 regions of India, in Tamil Nadu, Maharashtra, Jharkhand, and Chandigarh, and included over 14,000 individuals. It found that half of people in India in these 4 regions were physically inactive. Half of people were doing no activity. Fewer than 10% were doing any recreational physical activity. And again, surprising, which is different from other countries, is that physical inactivity was higher in urban areas and among women and among those with higher socioeconomic status. One thing I want to now focus related to physical activity is what we call sitting time. This has been a recently appreciated cardiovascular risk factor, and I have a nice figure from a meta-analysis which was published a few years ago. On the x-axis here, you see sedentary time, which is the proportion of time that people are generally sitting and not physically active. And on the y-axis is what we call the pooled hazard ratio of all of these studies on the risk of cardiovascular disease. Now, what you can see here, after 6 hours of sitting time, that is spending 6 hours or more a day sedentary, and of course this includes sleep time, and then as it goes higher, 8, 12, 10, 12, 14, 16, the risk of cardiovascular disease increases. So if you're sitting 12 hours a day, there's a 1.15 approximately higher risk of developing cardiovascular disease. Just by sitting, just by not being physically active, these metabolic abnormalities are affecting our heart vessels, our blood vessels going to the brain, our blood vessels everywhere, our arteries, and leading to the development of disease. Activity is incredibly, incredibly important. So is minimizing stress, anxiety, and anger. So stress leads to an increased heart rate. It leads to a higher blood pressure. It can also lead to a process of what we call chronic inflammation that can lead to coronary heart disease. This can lead to a high sympathetic state, what we call fight or flight, and leads to clumping of platelets that can lead to the heart attack, those pictures that I showed you at the beginning of the presentation. Unfortunately, stress and anxiety can also lead to other maladaptive behaviors that might increase cardiovascular risk. These include eating oftentimes unhealthy, sugary, sweet, or high fat content foods. This might include smoking. This might also include drinking alcohol. So it's incredibly important to manage these factors. It's important to manage stress, to control anxiety, to control anger, so that these physiologic processes and the possible maladaptive behaviors that lead to increasing rates of cardiovascular disease can be controlled and reduced. Another thing that's been underappreciated is the importance of sleep. What I've shown here is the hours of sleep that an individual might get and the risk ratio for the development of coronary heart disease. The risk ratio is 1 for for individuals who sleep about 7 hours a day, a little bit lower even for those who sleep 8 hours a day. You can see the error bars here. But as you sleep less than 7 hours, as you sleep 6 and even 5, there's a higher risk for coronary heart disease. And as you sleep more, 9 or even 10 hours, there's again a higher risk of coronary heart disease. So ideally, sleeping approximately 7 to 8 hours a day on a regular schedule is important. Now, similarly, and this is recent data that were actually just published literally in the past week in the Journal of the American College of Cardiology, one of the top international cardiovascular journals, about the importance of sleeping and waking at regular times. So I want to first turn your attention to the top left quadrant. Here you see in green an individual and this individual's sleep time. And here's the time, and here are the days of the week: Sunday, Monday, Tuesday, Wednesday, all the way through Saturday. This individual goes to sleep approximately at the same time every day, at about 10 p.m. every day. Wakes up around the same time every day, about 5:45 p.m. This is what is termed a regular sleeper. The standard deviation of change of sleep duration is about 10 minutes. Sleeps only 10 more minutes or fewer minutes every day. And the sleep onset timing only varies by about 9 minutes. And then here's an irregular sleeper. On Sunday, the individual goes to sleep close to midnight, wakes up at 7:30. On Monday, goes to sleep at 8:30, wakes up at about 5:45 in the morning. And you can see on Saturday, sleeps at 3 a.m., wakes up at 6:30 a.m. These irregularities of sleep. Now, I want to turn your attention to the right side of the screen, which shows that if what happens for both regular sleepers and irregular sleepers in terms of the standard deviation of sleep duration. So if there's variation of less than 60 minutes, the hazard ratio for development of cardiovascular disease is the lowest. But if there's variation in sleep duration of higher and higher, of more than 60 minutes, more than 90 minutes, even more than 120 minutes, there's a higher hazard for the development of cardiovascular disease. So even differences in duration of sleep over a week can be associated with higher risk. Similarly, the sleep onset timing, the time that you go to sleep, if you go to sleep every night at 10 p.m., or within 30 minutes, the most regular, or if you go to sleep at much higher rates, greater than 90 minutes, again, a higher risk of development of cardiovascular disease. So sleeping, ideally, shown in this study of 2,000 patients, none of them had cardiovascular disease, and they all completed a 7-day sleep assessment. For all of these individuals, incredibly important, shows try to sleep on time and sleep for about the same duration. And ideally, that's about 7 to 8 hours every night. I want to also just end by talking about the importance of avoiding tobacco. Nearly 300 million people in India aged 15 years and over consume tobacco. Most commonly, this is the bidi. The smoking prevalence in India is nearly 1/4 of men and approximately 3% of women. Unfortunately, there is also a deleterious effect of secondhand smoke and also air pollution. The duration and intensity of smoking affect risk, with on average about a 2-fold increase in the risk of cardiovascular disease. This can be reduced through stopping smoking, through smoking cessation, as well as through reducing the intensity of smoking. Ideally, all tobacco products would be completely avoided. Now, I want to just discuss, I recognize that COVID-19, this worldwide pandemic, has affected all of us and has had a significant impact. And I want to just acknowledge this, and hopefully some of the preventative measures that I've described might be helpful. I recognize that COVID-19 has led to fewer checkups to assess blood pressure, cholesterol, and sugar. It's led to less physical activity because of the restrictions in place on activity and movement. This means it's also led to more sedentary time. Again, all of these associated with increased cardiovascular risk. It certainly led to more stress and anxiety as we see tens of thousands of individuals in India infected on a daily basis. It's also led to irregular sleep patterns and may have even led some people to use tobacco. So I think acknowledging the worldwide pandemic that we're facing is incredibly important. Recognizing it, recognizing the impact, and trying to spend the time and place the effort in improving our cardiovascular risk so that we can avoid a lot of those adverse cardiovascular events that I described at the beginning of the presentation. So in just the last few minutes, I want to talk, there's a lot of innovation in digital health technologies, and I want to talk a little bit about that and the importance of testing these measures and of them in helping preventative medicine. And we should be wrapped up in about 10 minutes, and then we can go to the questions. Can new digital technologies help? Can they help us to live healthier lives? Can they help us to improve our blood pressure, improve our physical activity, improve our cardiovascular risk, reduce the risk of stroke and heart attack? Well, certainly new technologies have been developed that can help us to monitor our blood pressure at home, that can help us to monitor our activity and even increase it. They can help us to increase standing and activity time and decrease the sitting time. They can help us to monitor the quality and quantity of our food intake, maybe even reduce stress. But really, it's cloudy. There's a lot of potential, there's a lot of hype, but I strongly believe that we need data, we need evidence to guide us in the potential uses of these digital health technologies. But there's a lot of excitement about digital health. This is the president of the American Heart Association. In September of 2018, Apple announced the release of a feature for EKG and development and detection of irregular rhythm notifications. At that same time, the president of the American Heart Association was there on the main stage with Apple describing the potential of innovative digital health technologies. Mr. Tim Cook, the CEO of Apple, has said that Apple's work in health and wellness is an area that I believe, if you zoom out into the future and you look back and you ask the question, what was Apple's greatest contribution to mankind? It will be about health. Digital health technology companies, digital health companies are all in on digital health. There is tremendous investment and potential in this area to help us to live healthier lives. But I still think we need to test these. We need to make sure that they're helping us to indeed live healthier lives. Here's an example of an instant blood pressure application. This is an application that was developed where a smartphone was placed on the left side of the chest and the right index finger of the smartphone camera. The idea was that this could help people to measure their systolic and diastolic blood pressure. If you measure it, hopefully you can reduce it. This spent over 150 days as one of the top 50 best-selling iPhone applications. Nearly 1,000 copies were sold daily. People were paying $5 US. But how did this application really work? Well, here's the data. On the x-axis here, we have the standard blood pressure measurement through well-established sphygmomanometer, what we use to measure blood pressure. On the y-axis, the blood pressure measurements that were made through the device blood pressure measurement. And there was wide variation Blood pressure using the device might measure a blood pressure of 130, but the blood pressure measured through standard blood pressure measurements, it might be 110, it might be even 95. Or the standard blood pressure might measure 130, and this device might say your blood pressure is 108. It might say your blood pressure is normal, but actually you're hypertensive. So there were both false negative findings and false positive findings, and potentially risk in using a digital health technology that might not be as accurate as we need. And finally, I'm a big fan of randomized clinical trials because I think that they give us the best possible data. This is the IDEA randomized controlled trial. Nearly 500 people with a body mass index between 25 and 40 were prescribed to a low-calorie diet and physical activity. And there were two arms in this study. The first arm was recommended to perform self-monitoring of diet and activity, while the other arm was also asked to do self-monitoring of diet activity, but they also got a wearable device. This helped to measure their physical activity and energy expenditure, just like a Fitbit or an Apple Watch, or some of you may have seen Amazon release a device just a couple of days ago. And then the individuals were followed for a total of 2 years, for 24 months. And here's what happened. Again, one arm getting the standard intervention, monitor your diet, monitor your activity, and then the other arm getting a wearable device. Here's what happened. In the standard intervention group and the enhanced intervention group, from baseline to 2 years, there was significant weight loss. But the estimated weight loss was actually higher in the group of people who got the standard intervention, who were just asked, monitor your diet and your activity. It was actually lower in people who had the activity monitor. And it's statistically significant difference. So this shows, obviously there's tremendous potential for digital health technology, but this shows we need to test them. We can't just take it for granted that buying a device that's going to track our steps or our activity is going to change our behavior. And this really emphasizes the importance of self-monitoring. So again, I think we need to test. I think there's a lot of potential, but I think it's very important that we employ, to the extent that we can, preventative therapies to help reduce our risk of cardiovascular disease. I want to again thank Professor Subhash, Ms. Anupma Thakur, Dr. Chan, all of you for taking the opportunity, taking the time to spend and to learn about cardiovascular disease and preventative measures and some of the novel therapies. This is my email address at the University of California, San Francisco. I welcome your feedback. And at this point in time, I'll now stop the screen share and I will go forth and take questions at this point in time. Just 1 second, please. Just stop the screen sharing and get your questions. Okay, so let's see here. Just trying to open the chat window. Sorry, 1 moment, please. Okay, I'll start at the bottom and just make my way up. Being a heart patient, I've never adopted a quantitative restraint or control on my food intake. Keep feeling quite hungry throughout the day, but weight and weight and blood pressure absolutely normal. Yes, it's hard. Many individuals do feel hungry, but people are able to adjust over time as possible to reduce the intake. And there are some foods that can help to satisfy the hunger, which are healthy. In particular, nuts, peanuts, walnuts, almonds might be a good recommendation, again, which are very healthy. Is systolic blood pressure more dangerous than diastolic in the case of a heart patient, or is the vice versa true? So it's a good question. Both of them are important. After approximately the age of 55, the systolic blood pressure is more important than diastolic. Both of them are important, but we tend to generally focus on the systolic, which is the highest blood pressure that goes out. There are some people who, however, who have isolated diastolic hypertension, which should also be controlled. The side effects of metformin for diabetes, does it induce lymphoma? I'm not aware of the association of lymphoma. The side effects of metformin. Metformin is an excellent medication for diabetes. It helps to reduce cardiovascular risk for sure. Some of the patients sometimes get some abdominal discomfort, which is sometimes rare, and sometimes a feeling of fullness. But most of these are most of the medications are exceptionally well tolerated. It's not recommended in some people with liver or kidney disease as well. There's a question saying, due to the COVID-19 pandemic, I'm finding it difficult to go for a brisk walk with a mask. I reduced my walking to just 5 kilometers. Am I risking otherwise avoiding crowded places, being a heart patient, virtually confined, except a morning workout in the residential complex? Am I compromising my risk factors? This is a great question. Again, I think I have a lot of humility. It's not easy. COVID-19 has thrown a real wrench and has made it harder. I think walking anywhere is important. Walking in one's residential complex, I think walking in the morning, I think these are excellent ideas. And trying to walk to the extent possible is incredibly important. Someone's asked for the published material. Yes, I'm happy to share. As I mentioned, all of my slides, not all of them, but I had a substantial portion of any of that presented data. I tried to have peer-reviewed journal publications as reference as well. There's a question about refined vegetable oils. They tend to get oxidized rapidly upon heating. Do you believe the promotion and consumption of vegetable oils is a crucial reason for metabolic diseases? Yes, absolutely. Unfortunately, the refined vegetable oils, which are common in our Indian diets, are a risk factor, and they do lead to the development of cardiovascular disease. And it is important to try to substitute those out and to try to use olive oil to the extent that's possible. Workout and good quality food is invariably making me sleep after the breakfast for 1.5 to 2 hours due to workout tiredness, and at evenings a nap too. Everyone's different. For some people, a nap is important. The key is getting the amount of rest that's needed. There are also many reasons that people may not sleep well at night, things like obstructive sleep apnea that can sometimes be helpful to get tested. Someone said increasing water intake can also help. I certainly agree. Staying well hydrated is important, especially during the summer. It's becoming difficult to sleep for more than 1 or 2 hours each time. Overall, sleeping for 5 to 6 hours in the 24 hours time frame, is it okay, or is it a disorder? Sleeping continuously does become more difficult sometimes with age. It is difficult, but it's important to try to, as I showed in the study of sleep actigraphy, to try to sleep on time and to try to sleep at the same time to the extent possible. And there are also lots of things that can be done to help improve the quality of sleep. For example, not going to the bedroom or not using the bed for anything other than sleep, for not drinking too much water or soda prior to the time of sleep, to knowing if one might be snoring and introducing to you being tested for things like sleep apnea as well. There's a question about does consumption of coconut chutney increase the cholesterol? It does increase the cholesterol. And again, remember, the key is not the overall cholesterol. You want to focus on either the LDL or the HDL cholesterol. So it can increase the LDL cholesterol, but again, everything in moderation. And the point of this talk is not to say don't ever eat kulfi. Don't ever have kaju katli. But the point is to say it should be in moderation. The point is not to say every single day you must exercise for 2 hours. The point is to say you should exercise more. The point is to say we should modify these risks to the extent that we can so that we can reduce the risk as much as possible. Someone said being stress-free life is the most important for everyone. I totally agree. I showed the slides on the importance of stress reduction and anger management. Tell us about the quantity of ghee or clarified butter that should be taken in the diet. This is a good question. Again, minimizing to the extent possible ghee and clarified butter. These are associated with increased risk of cardiovascular disease. It's difficult, but, and again, we can't completely change our diets. I'm not saying, you know, I'm also vegetarian. I'm not saying we should go and start eating fish. But to the extent that we can, we should try to reduce the consumption of meat. We should try to increase the consumption of nuts and fruits and vegetables to the extent that we can. I'm going just to the bottom now again for some of the more recent questions. I'm 70 years old with a coronary artery bypass graft CABG done 17 years ago. These days, I avoid the review by the cardiologist each year. In fact, not done for the last few years, but confident to pull along. Yet, you know, the goal of cardiologists like myself, you know, obviously we help to treat people who are in the throes of a heart attack, who suffered heart failure, but I think the greatest service that we can do is by helping people with the preventative lifestyle. I can help you if you have a heart attack or heart failure, but I can help you a lot more if I can help you to change your lifestyle, to sit less, to reduce stress, to eat healthier, to have more activity. Please talk about stents and their misuse in India. Yeah, this is an incredibly important topic. So, you know, in a lot of places, there is a focus. A lot of people just want a solution. They want to have a stent put in to treat a blockage that might be in place. What's actually been shown, some very rigorous clinical trials, multiple, including one that was presented just last year, have looked at patients who have heart disease and the placement of a stent, which can, what looks like open up the blockage. Now, in the setting of a heart attack, a stent is essential. I want to first emphasize, if someone is having a heart attack, acute substernal chest pain, chest pressure, it's incredibly important to get treated immediately and to get a stent put in to open up that blockage. But unfortunately, what's happened is people with stable heart disease who've developed blockages over time are getting stents more and more, and stents are actually not associated with a reduced risk of heart attack or of death from heart disease in that setting where people are not having a heart attack. So those of you or your loved ones may have developed heart blockage, may have received a stent, and that stent is not going to reduce the risk of heart attack, is not going to reduce the risk of death from a heart attack or from cardiovascular causes. It seems counterintuitive, but there are many reasons for that, which is related to the fact that heart disease is a progressive disease, it's a systemic disease of all the heart arteries. It's also related to the fact that heart attacks don't just happen from the narrowest blockage, they happen from other blockages. And unfortunately, there's been a lot of overuse and misuse. There are a lot of financial incentives for people to place coronary stents, but unfortunately, you know, it doesn't really help to improve cardiovascular outcomes. But again, I want to emphasize in the setting of a heart attack, it's important to receive treatment, but in the setting of stable heart disease, it's important to be taking these medications like statins, like aspirin, reducing blood pressure, improving diet, improving exercise. Is bypass surgery not needed these days? So this is a good question. So actually bypass surgery depends on the type of blockages and where those blockages are. But it is a helpful modality for people who do have severe blockages, in particular what we call multi-vessel coronary artery disease, multiple vessels being affected. Or I showed a picture at the beginning of the talk around the left main coronary artery, which is a major artery that then splits into the left anterior descending going in the front of the heart, the left circumflex going across the lateral wall. So any blockage there also would benefit from bypass surgery. So those are all the questions that we have. I know we've spent more than 90 minutes. I'd be more than delighted to answer any of your questions. I hope that this has been an informative presentation that has helped to show you some of the novel therapies development, but also the importance of avoiding these therapies through preventative behaviors. I'm happy to stay on and to take additional questions. I provided my email address. I welcome any feedback and welcome any questions. And I hope this has been informative. Again, want to thank Dr. Chan, Ms. Anupma Thakur, and Professor Subhash for inviting me, and to all of you for taking the time to listen and learn. I hope this has been of help to you.
Yes, thank you so much, sir, for sharing your knowledge and for very insightful and your and also Professor for taking the session and bringing us to Echocardiogram. Yes, thank you, sir.
Thank you very much, Anupma, Naresh, and Sankit, and all the participants for your valuable and interactive sections. Thank you, sir. Thank you very much. See you in another section. Thank you. Bye-bye.
Thank you.
Thank you very much.
Thank you.
Thank you.
Yes, thank you, everyone. Take care and stay
Hey,
safe.
Shivaji, how many people are logged in?
Anupma, can you confirm?
Yes, sir. More, sir, 100. More than 100 joined in today for the
Okay,
session.
thank you.
Yeah.
Okay, thank you.
Yeah, thank you. Take care of your hearts, everyone.
Thank you.
Yes, thank you so much, sir, Naresh, sir. Thank you.
Thank you.
Okay, bye-bye.
Bye-bye.
Take care. Thank you, everyone. Thank you, Dr.